Just exercise can be enough to trigger off an attack. Sometimes emotions can trigger it, sadness or even laughing. Different emotional conditions can sometimes trigger an attack. Irritating dust, vapour or fumes, petrol fumes, paint fumes, different sorts of things that people inhale that their respiratory tracts are sensitive to. One of the most common in the West, actually, is house dust mite feces. House dust mites are little creatures that live in carpets and beds and places like that. And their feces, people become sensitive to the waste products from house dust mites. Of course, the answer there is to try and get rid of the house dust mites. People can be sensitive to different animals, to different foods. So if a particular agent is triggering asthmatic attacks in particular individuals, they need to learn what those trigger factors are and, of course, avoid them. And as with all conditions, there is a genetic factor, a combination of intrinsic and extrinsic etiological factors. And we know that asthma is about 10 times more common in people that have a close relative who suffers from asthma. So I think we've seen that some of these causes could be allergic, like the animals and the dust, but other causes don't seem to be allergic, like cold air and exercise. It would be strange if someone was allergic to air. But allergy is a factor in many cases. And there's a condition called atopy, where people produce immunoglobulins, immunoglobulin type E in fact, very readily. And asthma is more common in these people. So there seems to be an increased sensitivity of the airway and an increased propensity, an increased likelihood to develop immunoglobulins to everyday substances. Then, of course, that everyday substance would act as the antigen, combining with the immunoglobulin, causing some sort of inflammatory response. So, etiological factors, very important to know about, so they can be avoided. So I think we can see that the nurse's role as a health educator is very important in asthma. And just a couple more points I'll mention before we pass on to look at clinical features. And one is that some studies have suggested that children who are breastfed are less likely to get asthma. So another reason for encouraging breastfeeding is that the children of breastfed mothers are less likely to become asthmatic. And it's also strongly believed now that mothers who smoke during pregnancy are likely to have children who are more likely to be asthmatic. So another good reason for advising very, very strongly indeed, for this and hundreds of other reasons, that mothers do not smoke in pregnancy. Very important. If you can possibly stop mothers smoking during pregnancy, you'll benefit the child an awful lot. Okay, let's go on now and consider the clinical features that we're going to see in asthma, the signs and symptoms. Well, the condition may occur at any age, and it often affects children. It often begins in childhood. And the attacks may be of sudden onset, although there may be some warning of a severe attack. But although the attacks do come on suddenly very often and without warning, sometimes, very often, there are warning signs that someone who is prone to asthma may get to indicate that a more severe attack is coming on. For example, if they need to use their inhaler more often, their bronchodilating inhaler. And if the relief that the inhaler gives is less effective than usual, or lasts for less than 4 hours, that's a possible warning sign that a more severe attack is coming on. Or if the individual is short of breath first thing in the morning or during the night, again, that can mean that the condition is getting worse and they may be heading for a more severe attack. Or if their peak flow readings are constantly lower than normal. Or if there's a bigger difference than usual between the morning and the evening peak flow readings. And any difference of more than 15% should be considered a warning sign. So if there's a bigger difference than 15% between the morning and the evening peak flow readings, or if the symptoms wake them up at night. So while attacks may come out of the blue, they may well be a warning that the condition is getting worse. So patients should consider these features and take advice if they find that the condition is getting worse. So recurrent episodes of shortness of breath and wheezing, often with a cough, is a fairly common complaint in asthma. And sometimes expiration is more difficult than inspiration, and the chest feels tight. Now, this isn't always the case. Some people with asthma will have great difficulty breathing in, but very often you find that they can breathe in quicker than they can breathe out. So they can go and then it's breathing out that's difficult, and you can hear them really wheezing and labouring to breathe out through these constricted, inflamed, narrowed bronchial passages. And the reason for this is that inhalation is an active process. The diaphragm goes down, the ribs go up and out. So the powerful intercostal muscles pull the ribs up and out. The powerful diaphragm goes down to increase the volume of the chest, to reduce the pressure, so the air is sucked in. So sometimes they can breathe in not too bad because these powerful muscles facilitate that process. But expiration is a passive process. It's called the passive recoil, in fact, of the thoracic cavity. The intercostal muscles just relax, the diaphragm relaxes and goes back up to its normal domed position. And so it might be harder for them to breathe out than to breathe in. So wheezing, yes, possibly on inspiration, more commonly on expiration. Expiratory wheezing, a very common feature during an asthmatic attack. So expiration is often more difficult than inspiration, and the chest feels tight. And you can also sometimes see them using the accessory muscles of respiration. These are things like the pectoral muscles on the front that help to move the chest up and out in order to increase the volume of the thorax to facilitate inspiration. So because the patient is distressed and breathing is very hard work, there's an attempted increased respiratory rate anyway, an increased pulse rate. And of course the amount of air that the individual can get in and out of their lungs in any one breath is going to be less. So to try and compensate for that, they'll be trying to breathe quicker. So there may be increased respiratory rate and almost certainly increased pulse rate. And of course, when you can't breathe, this is very, very distressing. So the anxiety may well be severe. The patients feel like they're going to die. Very distressing condition. So severe anxiety. That often causes restlessness. And the patients feel like they're suffocating. They just can't get their breath, or they can't breathe out. Very, very anxiety-provoking situation. Another feature that may occur is central cyanosis on the chest and abdomen. So cyanosis centrally. And if the hypoxia becomes severe, that can embarrass essential organs such as the heart and the brain. So consciousness may be reduced, for example, because of cerebral hypoxia in a severe attack. and other organs may also